We're going to finish immunity and finish up by talking about a couple of different things. First of all, we want to take a look at the white blood cells or leukocytes themselves. If you have leukocytosis, what would that mean? Might be something that you should look up so that when we discuss those particular things, you'll be ready for those. The normal white blood cell count is 4,500 to 10,000. If it is less than 4,500, we have neutropenia. And if it is greater than 10,000, we have what? And considering all of the different white blood cells that are part of the immune system, you have to consider what each of their job is. So you have the neutrophils that show up as the first ones on the scene. You have eosinophils and basophils. The neutrophils make up the greatest percentage of total white cell count, and I believe your Iggy book talks about 55 to 75%. Other white blood cells are the macrophages, the monocytes, lymphocytes, and then each specific group is going to have a specific job duty when we implement our immune response. So continuing on a little bit about cellular mediated immunity. Cellular mediated immunity is the body's way of protecting itself and being able to differentiate between self and non-self cells. Our cellular mediated immunity helps prevent the development of cancer cells. So our natural killer cells, like we talked in an earlier presentation, are the ones responsible for going in and destroying specific mutant cells or carcinogen cells. So we do utilize those with cellular mediated immunity. Also with cellular mediated immunity, cytokinins are released, and those are messenger cells. And those messenger cells have a specific job function in the respect that they're kind of the leader of the pack, and they tell all of the cells when to take action. I noted that my word got cut off a little bit with the previous slide, but again, the cytokinins are responsible for telling the white blood cells when and where to go to help fight off antigens. With transplant rejection, when we talked earlier, we talked about the human leukocyte antigen, or the HLAs, and that those are the cell's particular fingerprint. That is how everyone is different from each other, and the only time there would be an identical one is if there were identical twins. So with transplant rejection, that occurs when we have a rejection to an organ that is put inside of us from someone else. With transplant rejection, patients that have transplants are required to stay on immunosuppressive drugs, steroids, things like that. So the different types of transplant rejections are listed out on your slide. With the hyperacute rejection, that occurs immediately on transplantation. It is antibody mediated, and the antigen antibody complexes form in the blood vessels of the transplanted organ. Because the recipient, the blood, already has pre-existing antibodies to particular antigens, including different blood types, and so the antigen antibody complexes adhere to the lining of the blood vessels in that donor organ and causes the complement syndrome to be activated and triggers blood clotting. So then what will happen is that organ will become necrotic and will end up dying. With acute rejection, that first occurs about 1 to 3 months after transplantation, and then the patient may have periodic episodes of acute rejection. Oftentimes the cells responsible for this are going to be the T cells and the cytotoxic cells, or the natural killer cells. Chronic rejection really, your book talks about it not being clear, but it's very similar to chronic inflammation and scarring. So these smooth muscles of blood vessels kind of overgrow and occlude the vessels. The organ tissue of the donated organ are replaced with fiber like scar type material, and so then as time progresses with chronic rejection, that new organ will become very fibrous and result in chronic ischemia. So management of transplant rejection is really it involves all three components of immunity. So but the cellular mediated immunity is really going to be the one that plays the most danger in transplant rejection, and that's due to the human leukocyte antigens, and it's the body's ability to recognize self from non-self cells. It also, if you look at table 19.4, we'll discuss these more in class, but it talks about the immunoglobulins. And the immunoglobulins are basically the body's antibodies that the body has produced against specific antigens. And it talks about IgA. And IgA is really highly prominent in mucous membranes, interstitial mucosa. Typically, it's found in those mucosal areas versus circulating areas. It's great because it prevents or helps prevent upper and lower respiratory tract infections, GI and GU infections. And so with the transplant rejection, the thing with that is that the IgG is really involved in the antibody department of the cellular mediated non-self killing aspect of immunity. And so the idea behind management is that we need to inhibit those antibodies from acting on that new organ. So typically what the patient will be on are continuous immunosuppressants, and those drugs are utilized to suppress the immune response. So cyclosporine, Noril, Gengraf, those are all different immunosuppressants. These are listed out on page 315. I also talked about the corticosteroids are also utilized. So prednisone or prednisolone are going to be very well utilized to help control the inflammatory response. The adverse effect is, how do these drugs affect the patient in the long-term treatment? They are going to be at a much higher risk for bacterial infections because their immune system is suppressed. So we do need to educate these patients to kind of stay away from crowds that might be sick and try to keep themselves as healthy as possible. With rescue therapy, that's used to treat acute rejection episodes, and these may be used in addition to or in place of the maintenance drugs that we have talked about. But you may see that antibodies that are produced in animals may be injected into the patient to prevent the reaction. The basic idea behind that is we want to prevent the person's body from rejecting the organ that has been transplanted and prevent any further antibodies from being made that might increase the incidences of rejection. You'll notice that the next few slides are iClicker questions, so I would take a look at those, and we will discuss those when we meet in class. Have an idea of what your answer might be when you are looking at these, so you have a rationale to back up your statements.